afternoon session. The first discussion will be Put the Shoulder to the Wheel. As speaker, we have with us Dr. Ashish Kumar, Senior Consultant Anesthesia from Westfalls Klinikum, Kaiserslautern, Germany. Sir has a strong academic interest in regional anesthesia, education and examination preparation, pain interventions, emergency medicine, and intensive care. To give cadaveric insights, we are fortunate to have with us Dr. Sandeep Devan, Consultant, Academic Director, Department of Anesthesiology, Sancheti Hospital, Pune, Chairperson, EURA India, Chairperson of EURA RCT Board, and also Chairman of the Cadaveric Research Academic Board under EURA. His area of expertise is, of course, regional anesthesia, pain management, training and teaching of postgraduate and postdoctoral students, and especially cadaveric anesthesia techniques. We have already seen Sir demonstrate beautifully blocks from the OT today in the morning. And to moderate the session, may I request Dr. Shishir Agrawal to kindly join us. Sir is Director Anesthesia, Apollo Medics Hospitals, Lucknow, with special interests in regional anesthesia, pediatric anesthesia, transplant, robotic, ortho, and onco-anesthesia. As a part of the panel, may I also request Dr. Divesh Arora, Director and Head Anesthesia, Asian Hospital, Faridabad, to kindly come to the dais. Dr. Amitnath Mishra, Director and Head, Orthopedics and Joint Replacement, Yatharth Super Speciality Hospital, Greater Noida. Dr. Abhisar Katiyar, Senior Consultant, Robotic Surgeon, Orthopedics and Joint Replacement from Yatharth Hospital. Dr. Amitnath and Dr. Abhisar. Okay, they are unable to join us. Can I now request Dr. Pradeep Chaudhary, Head Physiotherapy Department, Orthopedic Rehabilitation. Dr. Amit will be joining us shortly. Dr. Pradeep, yeah. Dr. Ashish, I believe, will be joining us online. Welcome, Dr. Ashish Panda. The stage is yours, sir.
Welcome. Thank you so much. Thank you so much. Thank you for your kind introduction. Can you hear me?
Yeah.
Now I will be sharing my. Hello. Yes. Can you see it?
Yes. No. Yeah.
So, good afternoon, everyone. Thank you for your kind introduction. It's truly a privilege to be announced this order of faculty members. I know many of them. I come from NC, and during my training days, Dr. Jayashree Sood, it's nice to see them. And it puts me an extra bit of pressure because he has recently got her shoulder surgery done. So I hope I'll do justice to this topic. I see this meeting also as a training, a learning experience for me, and I'll put a few of my words to this collective wisdom. Being physically there, obviously has a different energy, the human interaction, the informal discussions, and the shared learning. Unfortunately, that was not possible for me, so I'm grateful for the opportunity, and it allows me to connect to you virtually. I cannot start before thanking Shuman. I know him long back. This conference is very much his brainchild, and it's inspiring to see the vision and the effort behind it. I hope we can start it on a great note today. Like many of us, I trained in a time when shoulder anesthesia felt wonderfully simple. Just one block, problems. However, life, patience, and the lungs have seen taught me otherwise. I have nothing to disclose except for a few images that were generated by ChatGPT, and they are, it doesn't do the blocks yet, but it is learning very fast. Before going further, let me clarify that what this talk is not about. I won't teach you blocks you already perform perhaps in your sleep, and I won't dissect the anatomy either. That honor belongs to our next speaker, Dr. Sandeep Diwan. I know him personally, and I personally consider him like a Virat Kohli of regional anesthesia. So my role today is very simple, to show you how we think, not how we do. This is not a tutorial, it's a clinical decision-making cheat code. Now I greet you from Rheinland-Pfalz. It's southwest part of Germany, a region of liver, vineyards, castles, that too much good wine for an anesthesiologist living. Now I give a reason to attend a meeting in Germany. In my setup, it's a first Klinikum in Kaiserslautern. It's a very big hospital, tertiary care setup with 1400 beds. We have our own medicopter and medical intervention car. And because of the trauma situation, we got a lot of patients. We have had 5 orthopedic theaters. It's a certified shoulder centers, and we do around 30 shoulder surgeries in a week. That's in ambulatory setup and inpatient setup. We do all kind of shoulder surgeries in our setup, maybe inpatient or ambulatory, right from clavicle to different pain patients, scapular surgery, complex shoulder surgeries, arthroplasties. Now, regional anesthesia around shoulder joints, it's like we have so many blocks that have come up over the time, and it has made everything so complex nowadays. Regional anesthesia, however, I see it's like a puzzle. These various blocks, they are there because of the multiple innervations. There are different kind of surgeries that are done, minimal invasive to very complex ones. The patients itself have changed over the time. We have more patients with diseased lungs, we have obesity, we have sleep apnea, and various traumas, IP traumas, at least in my area. No doubt that regional anesthesia has expanded to accommodate all this. However, we are left with a clutter. And with this clutter, one side doesn't fit all. Now, I'll like to suggest two papers from 2017 from Dr. Al-Bugakli and from 2020 from Dr. Feigl and his colleagues, which understand, like I said, Ivan will go into details of this, so I'll not touch upon the details. How the main this clutter is because we have the shoulder area regional anesthesia is not just one block, it's a risk benefit analysis between the analgesic completeness and the respiratory safety. So, and that also set up the logistics that is involved, like an ambulatory setup or an inpatient setup, and we also understand the surgical target. So it creates a multiple dilemma, and we try to perhaps point this problem, this clutter. To declutter this, we have to think in 3 ways. The layer 1A of thinking is like patient phenotype. The layer B is the surgical target or dermatome or structure involved, and the layer 3 is the care pathway or the logistics. The best block is, I would say, is not one that fits the surgeon, but that fits the patient. The mindset has also changed over the time. Earlier we used to think that which block gives the best shoulder analgesia. Today the more relevant question is which risk this patient can afford. And very often that risk is respiratory. This is where the hemidiaphragmatic paralysis or HDP, it comes into the conversation. It is either present or it is absent, but its clinical impact is always graded. And that grading depends entirely on the patient that is in front of us. That's why we don't need a single risk score. Hemidiaphragmatic paralysis is always the interaction between the anatomy, that is the plexus, the physiology, that is the patient, and the context, that is the procedure. It is never the block alone. So the risk assessment, we say it in our setup a 3P model, like the patient, plexus, and procedure. We always start with the patient. Can this patient lose about 25% of the lung function on one side? In a healthy adult, the answer is often yes. But once you see red flags, like inability to lie down or orthopnea, that same physiological drop becomes very meaningful. Hemidiaphragmatic paralysis risk is also not just about the patient, it is also about the procedure and where we inject. What setup and what surgery are we talking about? And which block are we exactly performing? All we know that the closer you inject your local anesthetic to the C5 nerve root, the higher the likelihood of phrenic involvement, regardless of the intent. We all know that when we inject very close to the C5 nerve root, the spread of the local anesthetic always goes near the phrenic nerve. So that's why over the time, so many phrenic nerve sparing techniques have gained attention. Not because the classic interstitial block suddenly stopped working, but because our patients have changed and our tolerance for avoidable respiratory compromise have dropped. In healthy adults, hemidiaphragmatic paralysis generally cause 20 to 30% reduction in the forced vital capacity and about 20% reduction in the FEV1, which is, however, very clinically silent. To put it another way, hemidiaphragmatic paralysis is not a complication, it's a predictable pharmacological effect. With risk factors, the same physiological drop becomes very symptomatic, patients are dyspneic, they desaturate, they panic, and there is a delay in discharge. Very important is that we should not misunderstood the concept that phrenic sparing is phrenic zero. We always, if you are talk about phrenic sparing, you always mean some sort of phrenic involvement. So if we always do the risk assessment, we have a step analysis. The stepwise bedside approach is to assess the phrenic nerve, the respiratory reserve. So the first is that does our regional anesthesia procedure involve phrenic nerve paralysis? And we do a subjective screening, which is the general basic clinical questions. Do you feel short of breath? It is very, and if the symptoms are not there, we do routine monitoring. If the symptoms are there, we suspect hemidiaphragmatic paralysis. Then go to step 3, and then it becomes objective. So we look for the respiratory rate, we look for the slow breathing, we use for the use of accessory muscles and chest expansion. Very important to note that the saturation will still be normal. Then the next step, the step 4 involves, does this patient have inherently some reduced lung reserve, like a patient with COPD, or the patient is for ambulatory setting, or has sudden heavy sedation? If the answer is yes, we have a very low threshold for ultrasound. If no, we just observe closely and we assess. And we all know that diaphragmatic ultrasound is the gold standard to check hemidiaphragmatic paralysis. A reduction of excursion of 70 to 75% is suggestive of hemidiaphragmatic paralysis, a partial hemidiaphragmatic paralysis. If there is a paradoxical motion, we'll know about complete hemidiaphragmatic paralysis. In our setup, to ensure the patient safety, we have started putting a wristband. I'll just suggest that if it is possible, put it into practice. The wristband, like it is written in German, the English translation would be the wristband. It says that regional anesthesia has been applied, and that numbness and temporary weakness may be expected, and the patient may have a breathing difficulty or uncertainty which must be reported immediately and without forcing any further movement. It just ensures our safety. With this small change, we have detected many patients who are at risk. One must know that dyspnea, we have a rule of thumb. Dyspnea after the shoulder block is generally hemidiaphragmatic paralysis until proven otherwise. The risk of hemidiaphragmatic paralysis depends on the various blocks. If you see the comparative data, the pattern is very clear. The classic interscalene block carries a very high risk of hemidiaphragmatic paralysis. Low volume and supratension blocks reduce it but don't eliminate it. Postoclavicular blocks or combined suprascapular axillary blocks or clavipectoral fascia blocks and carefully placed ejector span in a block have shifted us farther away from training nerve, but each with a trade-off in analgesic coverage. So it's a balancing act between analgesia quality and the pulmonary desire. So this brings us to the decision making in practice. So step 1 is we assess the baseline pulmonary reserve. Is it low, moderate or high risk? It is based on clinical test and the pulmonary functional test if it is available or advised. Second, we ask the patient, can this patient tolerate the expected hemidiaphragmatic paralysis related reduction? Step 3 is we define the surgical analgesic requirement. Is it only arthroscopy or it's open or fracture or arthroplasty? And then we choose the lowest clinic impact technique that still meets the analgesic goal. We always use multimodal analgesia with NSAIDs and dexamethasone. And the whole concept is that it's a clinic sparing technique of choice and not a gamble. So we integrate all this into this algorithm that we have defined for ourselves. The first step is this patient at risk of pulmonary compromise? And the risk, as shown in the right side, these are all the risk factors. So the answer is generally binary. It is yes or no. If it is yes, our strategy is immediately shift towards the training sparing techniques. So we put training sparing blocks. The first choice is in general supra-trunk block. If somebody is well versed, like we have different grades of training. If somebody is well versed with the costoclavicular block, then he can put it, or a suprascapular or anterior axillary block, then also do it. It depends. This is the general algorithm for the whole department. It depends. We have ensured flexibility. Depends on the expertise of each who is doing it. We also put the catheter if it is the surgery demands it or the patient is for inpatient intake. Now, if the answer becomes no, that is the patient has no relevant pulmonary risk, our approach becomes simpler and it is more permissive. In these patients, we routinely perform interscalene block as our first technique. Importantly, this is usually done in low dose block, that is, we inject less than 8 ml of local anesthetic in every patient, which provides reliable analgesia while still we are limiting the proximal spread. This allows us to balance the analgesic effectiveness and the safety without unnecessarily escalating to more complex combinations. Regarding the different surgical techniques and the different pain generators, I will not touch upon in details because I think Dr. Divan is the best person to talk about it, where the pain occurs. It is a bone pain or a muscle pain or dermatomal pain, and it is depends on the which fracture is there or where is the pain generated. However, it is very important is that not all soldier surgeries hurt in the same way. So the patient care pathway and logistics plays a very important part. In modern shoulder surgery, especially the ambulatory surgeries, the primary constraint is very simple. We always ask, can this patient go home safely, comfortably and confidently? This changes everything. So respiratory safety has become the discharge safety. A degree of hemidiaphragmatic paralysis or a motor block that may be acceptable for an inpatient may be completely unacceptable for a same-day discharge patient. In our experience, motor block delays discharge more often than the pain does. And then there is rebound pain, classic nighttime failure. A great post-anesthesia care unit pain score doesn't always necessarily translate to a good ambulatory outcome at 2 a.m. in the night. And this is why the patient education is not optional. If the patient doesn't understand what to expect, when to take the oral analgesics, and how the block will wear off, even a technically performed block, a well-performed block can still result in dissatisfaction and readmission. In ambulatory surgery, the resonance is much, it's more of a logistic tool than an analgesic tool. Based on all this information, this is our second algorithm based on the surgery and the pathway. So either we have a simple arthroscopic surgery, which is usually outpatient pathway. In our setup, the majority of the surgeries, they go in the evening to back to home. For this, our default strategy is single shot supratrunk block. We do have the option of a suprascapular nerve block, usually performed by an anterior approach, and this works well in experienced hands. However, we have consistently found that once we remove the unnecessary complexity of from the arthroscopic surgical point of view, the supratrunk block gives a very reliable and consistent analgesia, especially for the capsular pain. So for routine outpatient arthroscopy, supratrunk remains our choice of product. Complex shoulder surgery like arthroplasty or replacements, or complex rotator cuff surgery, or a patient who has polytrauma, these patients are generally taken in the ward, and the pain is deeper, long lasting, and very critical to the rehabilitation. In this case, our standard approach is interscalene block with a catheter. However, if the patient has pulmonary compromise, we deliberately step away from the classic interscalene techniques and use a phrenic sparing catheter-based approach, like a supratrunk block or a postclavicular catheter block, to maintain analgesia while reducing the respiratory impact. When cases come up late in the evening, catheter expertise may not be immediately available. We also use a low-dose interscalene block, fully aware that its limitation, and then reassess the patient the next morning. If needed, we also repeat the block or place a catheter at that point of time. So the flexibility is built into the pathway. With respect to clavicle surgery, our go-to approach is clavipectoral fascia plane block combined with superficial cervical plexus block. Most of these patients are managed as outpatients, and this combination reliably covers the dominant periosteal pain. In an inpatient setting, we use supratrunk block for a better analgesia coverage. Scapular surgery is very complex and very nuanced. If the surgery involves posterior scapula, our primary choice of block is an erector spinal plane block, which can also be added with a suprascapular block or axillary block depending on the extent. If it is near to the glenoid area, we may need these blocks too. Now a small slide about where to put the catheter. It is just very important to know where to put it and where not to put it. For us, catheter placement is always a risk-benefit decision. We consider opioid sparing, motor sparing, and in an inpatient setting with physiotherapy that is put into place, and it depends on the patient compliance also, and the risk of rebound pain is there. So if the catheter is justified if the pain is expected to be severe, prolonged, and function limiting. If the pain can be managed reliably with a single shot, then the catheter is not necessary. And before committing to a catheter, we always ask, can a repeat single shot block be a reasonable alternative? In selected cases, especially early postoperative assessment where it is required, it works very well. When we do place catheters, common locations include interscalene, postoclavicular and anterior suprascapular. We choose according to the patient risk and the surgical target. There is also a growing evidence that if you use prolonged regional anesthesia and pain suppression with catheter technique, it lowers the incidence of chronic post-surgical pain, PSP. It is mainly for the complex rotator cuff repair or shoulder arthroplasty or redo surgeries. Our technical principles are very simple. We use lower concentration, we use a continuous background infusion, and we limit it for 2 to 3 days. The goal is that the patient is able to move comfortably on the postoperative day 2 or 3 with a minimal use or no opioid use. We taper it smoothly and we use ongoing multimodal analgesia and physiotherapy along with it and do a structured follow-up. A small slide, a small information about the pediatric regional anesthesia. As we all know, pediatric shoulder surgeries are generally managed conservatively. And surgery is very uncommon, and implant removals are usually done in an ambulatory setup. The children, it's very typical of them that they cannot reliably describe dyspnea or vocal weakness, and anxiety amplifies the symptoms. Therefore, in our setup, we avoid classic interscalene or DINS motoric block, especially in young children who have lung disease or bilateral involvement or are for ambulatory pathways. Our preference is single shot, training, and motor sparing block with multimodal analgesia. I'll just give you a link to this baby blocks. I found this website very helpful. You can just have a look at it. So pediatric shoulder anesthesia is not about the strongest block, but it is about matching the pain generators to the safest neural targets. So now comes the question, do I need to master all the techniques? In my opinion, my personal opinion, it's no. A more sustainable approach with a few blocks, deep understanding, wide adaptability, I would say that we can start with a small core set of blocks and then learn them well and then expand gradually as needed. What truly matters is the mastering the clinical reasoning, the sonoanatomy, and the risk-benefit balance. And it is not about collecting different techniques. So this sums it up. I'll give some take-home messages. Shoulder pain is multidimensional. It is not one nerve, one dermatome, or one block. The risk assessment, especially the respiratory risk, must come before the scanning or the needed assessment. Hemidiaphragmatic paralysis is predictable or block dependent and not a complication. Blood choice is therefore a clinical decision, not a technical achievement. A perfect block can still be the wrong one. And everyone should have at least one phrenic sparing option in their toolkit. The superior trunk block is a practical place to start. The question is not about which block is the best, but which block is the safest and sufficient for this patient in this surgery and with this level of expertise. So with that, I stop here. Thank you very much for your time and attention. I'll happy to take the questions or the comments during the discussion session. Now give the forum back to Dr. Anshuman and his team, and very much look forward to listening to Dr. Deva. Thank you so much for that.
May I request Dr. Sandeep Dewan to kindly take the stage for giving us the cadaveric insights.
Yes. So, good afternoon, everyone. नहीं वो connect करना पड़ेगा उनके पास है connector. So at the outset, let me congratulate Dr. Anshuman and his entire team for a wonderful live workshop. A big round of applause once again. Thank you very much, and we also thank everyone, the anesthesiologists as well who were, and thanks Ma'am Sood for gracing this occasion. So we are looking into a couple of things, and I thank Dr. Ashish for mentioning all those blocks. We had a wonderful time listening to him as well. So this was what Gardner had mentioned in the past about the innervation of the shoulder joint, where 70% had innervation through the suprascapular nerve and only 30% through the axillary nerve. But the recent trans model, now this is the neurodevelopment and this is the anatomic development where they do a lot of dissections and they've enhanced in their images. And they've showed the neural mapping where now they have introduced the subscapular, the lateral pectoral nerve as well as into this particular shoulder joint as well, which supplies the various quadrants, and they have the superior, inferior, posterior, and the medial quadrants. And it is the suprascapular and axillary which takes the main stage, while the subscapular has got the least. But to my surprise, there is actually one article which mentions 60% involvement with the lateral pectoral nerve. Now, interscalene block, as rightly mentioned by Dr. Ashish, he says that it should not be used in patients with phrenic paralysis. Now, in patients with severe pulmonary injuries, what we do is we insert a catheters and then we start injecting local. At 3 ml, you'll find that the entire interscalene groove is being loaded with the contrast and the local anesthetic. With another 3 cc, you will find that it overflows the middle scalene muscle. But with 9 ml, you'll find that it goes over the anteroscalene muscle, then blocking the phrenic nerve. So I think somewhere between the 5 to 6 ml in the interscalene with a catheter would be useful. The second thing was in this particular patient where we had a very frail patient, around 22 or 24 kgs, and she was posted for proximal humerus. I had to use an intracat 24 gauge and introduce local anesthetic through it, and we just use around 4 ml of local anesthetic for the entire proximal humerus. Now, this is a very important slide, and if you can see here what rightly mentioned again by Ashish, at the level of C5, you cannot distinguish between the phrenic nerve and the C5 root. So any local anesthetic injections which are very, very proximal to the C5, it's going to involve 100% of the times the phrenic nerve. Now, a phrenic nerve blockade in a 500 cohort patients, we found that in patients with ASA 1 and 2, they do not have any problems. But this comes to when they have ASA 3 and 4, which is usually the gold models. So a block here, definitely yes, 20 ml, even less than that, is going to produce phrenic paralysis. And if you move further away, that is a superior trunk block, that's what he explained, then the incidence is going quite low down. And this is what we accept. And this is what we expect in our routine clinical practice. And this is what we have been doing now, going more of superior trunk blocks as what we had seen today in the live workshop as well. So this is called as the infra-omoid superior trunk block. What we do is that we identify the inferior border of the omoid muscle, and we have to go in the paraneural sheath between the suprascapular nerve and the posterior division. So we have got the S suprascapular, we have got the P posterior, and we have got the A anterior divisions. So going between the paraneural sheath and try to inject local. So the first time when we did, it was an extrafacial injection, and the second time when we did, it was the intrafacial injection. So you have to limit your local anesthetic, do a dynamic scan, more cranial, and try to see whether it's extending at the level of the C5. Now, my friends, Xavier Salablanche and his team from Barcelona, they did this cadaveric study where they found that when you inject around 5 ml at this particular point, you will see that there is no anatomic phrenic paralysis. I call it anatomic because it's a cadaveric study and the clinical studies are different. Please do not extrapolate all the cadaveric studies to clinical studies. Please keep it in mind because the dynamics are totally different. So they did not find any anatomic phrenic paralysis. The next block would be the suprascapular nerve. Again, what Ashish had mentioned in his talk, we're going still low down, and this can be either proximal, where it just starts getting isolated from the posterior division. At this point that you start injecting your local anesthetic. Now, suprascapular nerve, as you have seen, it always has a major amount of innervation to the shoulder joint. So if I can go still more caudal, the drug actually goes more caudal and posterior and lateral. So there's less chance of the drug going in the cranial area. Now this by Harman Sembi, a group from Toronto, they found that when you inject around 5 ml, it does not stain the phrenic nerve at all. Now, this is one study. There are a couple of studies which come up and they mention that there could be, so it all depends upon the type of cadaver used, whether it's a formalin based, it's a thiol based, it's soft embalm, it's fresh frozen cadaver, or it's a fresh cadaver. Now, published recently in the literature. We have this article where we injected around 5 ml, and we wanted to see the mechanism why a suprascapular nerve would be useful for shoulder surgery, one, and second, why it should cause a phrenic paralysis. So when we injected, we found that when you inject the dense one where the suprascapular nerve has been injected, you can see the spread is going onto the posterior division and onto the anterior division and up to the level of C5. So this is how it spreads. So it's useful for the surgeries of the clavicle because you can see the nerve to subclavius has also been stained. It is useful for the shoulder surgeries, of course, because it is also covering the posterior and anterior division. You know that the posterior division gives the radial nerve as well as the axillary nerve, and the anterior division, it gives the lateral pectoral nerve. So all the nerves getting stained in these areas. The next, we wanted to see why the phrenic nerve should be stained. Now it's very interesting to realize that there is what is called as the phrenicoscapular connection. Now, phrenicoscapular connection is what described by Kodomo in 1960. He says that both the fascicles of the phrenic nerve and the suprascapular nerve, they originate from C5, and hence it is likely that if you inject the drug more distally, it can come more proximally. So that is what we did. We injected more distally in that fossa, and I can see that it goes dorsal. The ventral part is not stained. The dorsal is stained. It comes right over. It comes over the C5 and then it stains the phrenic nerve. So that could be the spread or the pathway of the dye. Now this article again, it mentions that 4.2 ml of dye was sufficient to have a phrenic sparing block with the suprascapular nerve. So now if you want to study any more further, you have to use a volume which is less than 4. You cannot go beyond 5 because this is the standard now. Because recently our article was rejected because we used 5 ml when it was already mentioned in the literature that 4.2 has been already been done. So now what do you do in a patient like this? We had a patient who had a huge mass and she was dyspneic and she was getting exhausted at each level. So we gave you can see the pattern of breathing, and we gave a suprascapular nerve block just around 5 ml, and then we went more into the axilla in the infraclavicular area, and we gave a small amount of local anesthetic at that point. So we injected around 10 ml in the infraclavicular area. Now where to inject in the infraclavicular area is at the level of the posterior cord, at the level of the lateral cord, because the lateral cord gives rise to lateral pectoral nerve, and the posterior cord gives rise to axillary nerve. So these two, and this is suprascapular. So you can strategize your blocks. It's not necessary that you need to give an interscalene block for all the patients. So this is how we could manage this particular patient. The question remains about the lateral pectoral, the axillary, and the subscapularis nerve. So those which are the red ones which have been marked are the nerves which we have not yet looked into. So that's what we are going to look into. Now, this is a museum in Coimbatore where I had a talk with the anatomist regarding the various anatomical variations. You can see the medial and the lateral pectoral nerve going right into the shoulder joint. You can see the suprascapular nerve innervating. You can see the axillary nerve innervating, all innervating the joint. So my question here was whether we can do an infraclavicular block and we can have the same type of analysis. So we have already seen how to approach the suprascapular nerve anteriorly. Is there any way of approaching the axillary nerve? So if you look at this particular cadaveric, this is a formalin based. If you expose the subscapularis fascia, you can see the axillary nerve and you can see the subscap nerve. It means that if you can look into with ultrasound into the subscap muscle, and if you can inject local just below the fascia, it can also cover these nerves as well. So this is what has been mentioned in the literature, and the cadaveric studies by these authors, they demonstrate that both these nerves can be stained with the injections of dye in this particular area. And this is what we have been doing. You can see all the hypoechoic shadows there. These are all the neurovascular structures, and if you inject local, you can see the spread. You can see them lifting up into the particular hypoechoic shadow. So this is what we have been looking into, and we combine with the anterior suprascapular nerve and the anterior approach to the axillary nerve. Now, should the infraclavicular block work for the shoulder surgeries? Now, there have been a lot of debate about this, and this is the study by Koyalamudi, you were talking about this, Devesh, the same study, I got it. So this is what, when they inject at the distal site in the costoclavicular, it stains the suprascapular nerve. I'm really not sure about how it stains. I'll have to look into what could be the probable pathway for this to go into the suprascapular nerve. But what we have seen in clinical practice, when I do my infraclavicular blocks and I do some contrast studies, I have seen that it goes right up to the interscalene area when you inject in the infraclavicular area. So probably this is a path which goes towards the interscalene area and might also provide analgesia for the shoulder joint. So probably like what we did in that case with a huge mediastinal mass, the suprascapular nerve block with the infraclavicular block would be a useful proposition for the shoulder surgeries. Then we have already described about the using a retrograde stimulating catheter in patients with shoulder surgeries. This has been, we have published in the literature. And this is a case series, of course, we could not do a randomized controlled trial because of certain issues. Now, we have all considered about the blocks which have been particularly useful for the awake shoulder surgeries, it may be, or it may be anesthetized patients. The last one which we have published recently is the proxy brachial block. I mean to say the cervical electrospinal plane block. Now, if you are injecting at a level of T2, that is at this point, when we inject methylene blue dye at a level of T2, we have seen it traveling right up to the level of C6. It stains the dorsal and the ventral rami, but it doesn't stain the phrenic nerve. We did also the cadaveric contrast. So we took the cadavers into the radiological suite, and we have performed the CT scan, and we saw that it also stains the dorsal and ventral rami, but never stained the phrenic nerve. So probably it is one of a better block which can be used, and we have used it. When we inject at a level of T1, we have seen the drug traveling right up to the brachial plexus. You can see the hypoechoic shadow, which is very close to the interscalene area. So what we do is that, like you have used PENG blocks for the patient to make sit, we use these blocks to make the patient sleep, because many of these patients, while sleeping, they've got severe pain. So we give these blocks in sitting position, awake, and then we anesthetize them. So these are the channels. You can see these channels here. These are the channels through which the drug travels through the middle skeletal muscles. So all the perforation channels and pores which communicate from the middle scalene into the interscalene area. Probably this is the reason why these blocks they act, even though they are given at a very distal site. So thank you. I'm very much within time. Thank you so much.
May I now request the panelists and the moderator to kindly take over the discussion. Dr. Amarnath Mishra, Dr. Pradeep Chaudhary, Dr. Devesh, and Dr. Shishir to moderate, please.
So by the time Dr. Shishir is getting ready, the conceptually what we have done is that we have tried to get the surgeons on board, the physiotherapist on board. बहुत बार क्या होता है कि anesthetist wants to give very good block and surgeons को लगता है कि भैया मत दो तुम, B की टाइम नहीं है या some other issues है, and हमने बहुत अच्छा ब्लॉक दे दिया, but the whole limb is numb now and physiotherapist problem होती है. So we have with us, the panel has everybody. We have the anesthetist, we have surgeons, and we have also physiotherapists. So this is basically getting their views from the surgeons to the anesthesia fraternity, what a surgeon basically wants from you or the physiotherapist wants from you. So usually हमें सर सर्जन की फोरम में बुलाया नहीं जाता है, but हम सर्जन्स को एनेस्थेटिस्ट फोरम में बुला रहे हैं सर. Thank you, sir. With that lighter note, let me give Dr. Shishir to start. Can you have the panel discussion shoulder, please, on the list?
Some other screen is connected here. Another screen is connected here. Another system is connected here. So please remove that system. Recent वाला. Recent. Yeah, देखा. It was open. Okay. Good afternoon, everyone. Thank you, Anshwan, and for organizing such a nice CME and workshop. So this is a panel discussion about shoulder surgery, and here I am not a moderator, just a curious child, Jigyasu Balak. I welcome all of you for this panel discussion. So shoulder pain is a very common. Around in 67% of the people, they experience shoulder pain one point of time in their life. So good pain management is the right of every patient, and it's our duty. So see here, these all are apples, but are they same? Similarly, you can see here, this is the shoulder surgery, arthroscopic surgery, another is the open surgery, hemiarthroplasty, and the trauma surgery. Are these surgeries same? So there are various types of shoulder surgery, like rotator cuff injury, shoulder arthroscopy, lateral repair, shoulder replacement, even the bicipital tendinitis type of surgery. So when you see pain, extent of the pain of the shoulder surgery, if you compare the pain of the rotator cuff repair with the hip replacement pain and the knee replacement pain, at point of day 2 and day 3, it is severe than the hip replacement and knee replacement pain. So I want to ask with my panelists, how different shoulder surgery requires different regional anesthesia approaches. So Dr. Sandeep, can you put some light on this? Dr. Divesh. So how different shoulder surgery requires different regional anesthesia techniques? Like how arthroscopy are different from the trauma?
Okay, as an anesthesiologist, we are supposed to know what all surgical impact each surgery would be having. So the best approach, what I think is, I discuss with my surgeon, like what is their expectation, what are the tissue trauma they are anticipating, apart from my little knowledge about the surgical discipline, and how early they would like to do a physiotherapy on that patient. So to take it forward, the arthroscopic surgeries are definitely different than the fracture surgeries. A fracture patient is having a pain, but once it gets fixed, the pain is of different kinds. So depending on the position, depending on the surgery, we have to tailor our techniques. For example, an arthroplasty patient of a shoulder, we need to think something beyond 2-3 days, as you said. Whereas in arthroscopic surgery, I would like to have a single shot block. This is how my brain works, and definitely we have a discussion with our surgeon. What are their expectations? Are they planning to discharge the patient same evening or next morning? And what is the plan for analgesia after the discharge?
Dr. Sandeep, what is your opinion?
I usually discuss with the surgeon regarding the grading of injuries. I discuss how much would be the, for example, if it is a subscap which they are going to pull over and have those, what to do to the anchors. So how many anchors? So it all depends upon the dissection, the pull of those muscles, and as well as the number of anchors that they would be inserting. So that could be equal to the amount of pain in arthroscopic surgeries. apart from the distension that's going to cause by the fluid, which they inject, and sometimes with very high pressures they do that. So that actually it doesn't come at all. It's like a visceral pain. So that is very difficult to take care of. So the interscalene block itself is not going to act. Neither a superior trunk block is not going to take care of that. So you require something beyond that. So we always add the multimodal analgesia. So a combination of all these things. If it's a simple procedure, we just do a very small single dose local anesthetic. But if it's a reverse shoulder surgery,
yes, right.
so probably depending upon the patient profile, we might insert a catheter in this particular patient. We do very less of catheter tactics, it's almost like coming to 0% now. We might repeat a block if the patient requires.
Okay.
So this is how we manage these cases.
Now this question is for the Dr. Amit. Which shoulder surgery is associated with higher post-operative pain and average duration of pain with this surgery?
Yeah, hi, I'm Dr. Amit Mishra. Thanks, Anshuman, first of all, for having us here. I'm inherently a shoulder and knee surgeon, and we don't call anesthetists to our forum simply because we are much more ignorant than you guys. We don't want to expose our ignorance as such. But shoulder-wise, shoulder itself is inherently a much more mobile joint than the hip and knee or any other joint in the body. So it's like a golf ball sitting on a tee. And as Dr. Divesh said, the expectations for shoulder surgeries are very different vis-a-vis basically hips and knees. So it's important to know which kind of shoulder surgery as well. So just to give an example, basically there are arthroscopic shoulder surgeries done for simply frozen shoulders. You know, you have a capsule which is contracted. We open up this capsule over 5 minutes. The guy is suffering since the last 8-9 months. His glenohumeral rhythm is altered, his scapulohumeral rhythm is altered, and we want to get his motion back the next day in a inherently mobile joint, more mobile than any other joint in the body. So that's the challenge. That's not only our challenge. We've opened up the capsule. Theoretically, the guy should be moving his shoulder completely, but the challenge is the anesthetist. Basically, if this individual is completely pain-free, and from whatever little I gathered, the axillary nerve, the suprascapular nerve, the subscapular nerve, the lateral pectoral, all of them are sufficiently, you know, kind of analgized, then this guy will start moving his shoulder completely normal from the next day. The rhythm, of course, takes time to come, but the range of motion will be complete. So that's the expectation of a shoulder surgeon in that sort of a surgery, in a frozen shoulder surgery where the capsule is being released. If it's a rotator cuff repair, now a rotator cuff repair, basically you don't need to actively mobilize the shoulder from the very next day. It's detrimental for various reasons. So you can passively mobilize it, but not actively. So the expectation for mobilization is not as much as a capsular release. And therefore, I mean, there are different kinds of surgeries. The reverse shoulder, which was shown out here, you can start moving the patient from the very next day because you haven't repaired any muscle out there, so you don't have the fear of basically tearing that muscle. So again, a reverse shoulder is akin to a capsular release. If there's a good analgesia, from the very next day, this individual is expected to move his shoulder. So it differs from surgery to surgery. But overall, as far as the shoulder is concerned, the requirement and accuracy of analgesia is much more. It's much more demanding for you guys because the expectations for mobilization are much more inherently.
Dr. Pradeep, you follow your patients very closely till the time of discharge.
Yes, sir.
So what is your opinion regarding which shoulder surgery is more painful for the physiotherapy purpose?
For physiotherapy purpose, sir. Where incision is given bigger, sir.
Yeah.
Trauma surgery is painful because initially what we do, we immobilize the arm. in trauma surgeries. Whereas in arthroscopic surgery, as sir also said, we have to be very aggressive in capsular release as well as rotator cuff repair. In rotator cuff repair, the exercises are very specific. For example, if sir repairs supraspinatus tendon, so in that case, what we have to do is we inhibit initial abduction of the patient and tell patient to active assistedly and passively mobilize the arm by not stressing the repair. So trauma surgery, I would suggest it is bit painful comparatively arthroscopic surgery, and our anesthesia team used to visit in the ward on regular basis to check the patient whether he is in pain or not.
And what are those surgery where you advocate early mobilization, and what is expectation from anesthesiologist or from us?
Sir, in every surgery we require anesthesia support for analgesia for reducing the pain score, sir. But yes, I would like to advocate arthroscopic surgery, sir, where we need more support from anesthesia.
Okay, like we should maintain the analgesia for 2 to 3 days at least.
Yes, sir.
Okay. So this is very wonderful study when we compare the pain score by different specialists. So you can see here, the when pain was reported by the physiotherapist. So according to them, rotator cuff injury was the most painful surgery. But by the surgeon and anesthetist, it was the open surgery which was the more painful. But according to nursing staff, the arthroplasty was the most painful surgery. So pain perception is different from different angles. So what are those indications where, Dr. Sandeep, what are those indications where we put catheters, your preferred site and technique to minimize dislodgement of catheter?
So for our institution, for arthroplasty, we like to place catheters. Otherwise, it's always a single shot block, whatever it is, maybe interscalene or superior trunk block, with 8 milligrams of dexamethasone as an adjuvant, and with multimodal analgesia, which takes care of it.
Sandeep sir, do you place catheters nowadays?
No, we have come out of all these catheter techniques. We just do single shot blocks. Catheters tend to come out if the patient starts moving next. So I think those won't be. But recently, what new we have started, if you can, we're doing something which is called as neuromodulation. Okay. So we are putting those stimulating catheters. We have done recently a randomized controlled trial, non-stimulating versus stimulating. So if these stimulating catheters are inserted, post-operatively we just stimulate that particular area. So the patient with a mild stimulation gets sort of a massage-like effect, plus the release of endorphins, and that will take care of pain. So we don't inject any local anesthetic in the post-operative period. And just before removing the catheter, we inject local anesthetic. And these catheters are very opaque. So you can also have a look at these catheters just before sending the patient to the ward.
So this was the question in our this year EORA final examination.
So if I might ask, so how long do single shots last?
So they last, say if you do it in the first half of the day, next morning by 8 a.m. the effect goes off.
And then if you want analgesia for about 72 hours, so it's parental or?
Then multimodal has to take over. That's the advantage of catheters if we place for arthroplasty. Then for 48 to 72 hours, we can just prime them up. Not as a continuous infusion we use, we prefer to give intermittent boluses. Because at times with continuous infusions, what happens is phrenic nerve palsy has been seen if we give it at 3 to 4 mLs. Just 1 to 2 ml per hour is more than sufficient.
So we used to inject 0.2% ropivacaine. So it all depends upon the concentration that you use. Rebound pain, we used to find it quite commonest at around 2 a.m. or 3 a.m. in the night. And there used to be a lot of problems with this. So we shifted from 0.2% to 0.375%. And we started adding dexamethasone in that, 4 milligrams. So this changed the scenario. It decreased the rebound pain. And as he said, they increase the duration maybe by another 5 to 6 hours. So by morning, when the patient just starts having mild pain, If you start injecting parenteral, that will take care of the next. So this is how you need to track these patients and have their pain scores monitored throughout in the post-op period. I'm very fortunate to have a team of junior consultants and fellows who monitor these pain scores throughout night, pain scores. So if it is any time it's more than 4, they inject opiate, that is tramadol. Meanwhile, they will be kept on diclofenac and paracetamol.
So again, these would be, so when you come to the parental thing, you are just injecting one go. It's not a PCA, it's not a continuous analgesia that you're sort of.
So we don't have those PCA modality, but I think they must be having.
So for shoulder, what we do is round the clock, as he said, PCM and Vovron. That is the best thing, and that too alternatively, not in a combination. Okay, and tramadol as a rescue, the nurse is instructed to give. For joint replacements, as a PCA IV morphine for hip and knee, we do it extra.
Yeah, and I'm just talking about shoulders. So you have peaks and troughs in shoulders coming through the day.
So what I've seen in my personal experience, 8 milligrams of dexamethasone perineural works wonders. Although it's slightly more dose, as he said, 4 milligrams suffices. But this has been shown that rebound pain won't occur to that extent what we do without a dexamethasone based perineural injections. A lot of research is going on the rebound pain, but dexamethasone has found to be useful in that. So PCA morphine is a good immediate rescue. So for hips and knees, majority of our work is hips and knee replacements. Shoulder very rarely we do. So we give PCA morphine to them under monitored HDU locations they are, so they can press the number of buttons.
So this was the aorta exit question this year, question number 7. So this was the question. 120 kg patient with a history of OSA has a proximal humerus fracture, is being posted for an open reduction and internal fixation with preload plate through a deltoid pectoral incision. So this was the question for the fellows. So I want to know from the experts, how will they answer this question?
So it's a little
Actually,
tricky one.
the most common answer was the scut block with the 10 ml of the local anesthetic. So
Instead of straightforward jumping to the choice of regional anesthesia, I would like to know more details about obstructive sleep apnea, because OSA patient doesn't mean that he or she belongs to a severe category. Okay. Then whether the patient is, as Dr. Ashish had mentioned, is able to lie supine is very important, because such surgeries are done in a beach chair position with just 15 to 30 degrees head up. Is the patient comfortable with that? And whether the patient is CPAP dependent or not. If the patient is not at all CPAP dependent and the surgery is going to take a little long and all, I might go for a GA with a regional anesthesia technique as an analgesia technique also. But if it has to be done under pure regional anesthesia, definitely my choice would be the superior trunk block, plus in combination of a supraclavicular nerve which supply the skin, and a deltopectoral incision at times may get escaped, so local infiltration on that site would suffice for me.
Dr. Sandeep.
We had 2 cases like this. We have reported it probably might get accepted if we have sufficiently given good revisions. We had a patient with a BMI of 53 and one patient with BMI of 51, and both were posted for same proximal humerus fractures. Now for this, we have the facility of introducing the stimulating catheter. So we know where exactly this catheter is positioned. We go as inferior as possible, close to the level of superior trunk, and start injecting very small of local anesthetic. Try to bring up the analgesic effect, and once that is done, that would be the limit. At the same time, a real dynamic scan, more cranial, just to see whether it has reached the C5 and C6 or probably the phrenic now. So a real dynamic scan, even with a single shot interscalene or the superior trunk block, would also suffice. So that would be the my answer.
Thank you, sir. So another question with the superior trunk block. So we are now more focusing on superior trunk block. So as this study, the joint is also supplied by the lateral pectoral nerve. The root value is C5, C6, C7. Lower subscapularis nerve, root value 5, 6, 7, and part of the posterior cord. Root value is 5, 6, 7, 8, and T1. Suppose you have to use regional anesthesia with the superior trunk as a sole technique. So do you need, this block will be sufficient? Means sparing these C8 and T1 will C7, 8, and it will not affect the quality of analgesia and anesthesia.
I am really unsure whether the posterior cord innervates the joint. That is one thing. Of course, it passes close to the joint, but it doesn't behave according to the Hilton's law. So that could be one occasion. Second thing, C5, C6, 7 can be blocked by the superior trunk, where all these nerves what you have mentioned, they are readily blocked. Posterior cord, I'm really not sure, and we have seen in our dissections so far we have not seen any branch from the posterior cord innervating the shoulder joint.
So given you a choice, if there is a ASA1 patient, which block will you prefer, interscreening versus superior trunk?
Interscalene. ASA 1, 2, even 3 to some extent, yes.
So just last 30 seconds to answer, as you said, it's innervation by posterior cord, that is through axillary nerve. The principal nerve fibers are C5 and C6. So every information which is traveling is through C5, C6, except for lateral pectoral nerve where C7 is an additional component. But because of anatomical studies, it has been seen that the contribution of C7 is negligible. That is why superior trunk block is working very well for shoulder surgeries as regards anesthesia and analgesia. So if tiny bits are still left, local infiltration can help. That's what is my opinion on that.
So again, Dr. Devesh, choice of your block technique when you are called by the emergency department to manage pain means pre-op pain management. I am talking about pre-op pain management in the emergency room. Which block will you prefer?
So again, the choice is very simple. As sir has said, ASA 1, 2, when there is no problem as regards the phrenic nerve getting knocked off. So my choice would be interscalene, and next subsequently, if there is a risk of hemidiaphragmatic, the consequences of that, then I would like to go a little distal to superior
Any
trunk.
other? Sir. And any capsular block or something like that?
So what we have tried recently is for adherent shoulders, like frozen shoulders, the shack block we have done, because I'm not a chronic pain physician, but my orthopedic surgeons do refer such patients, and at times for manipulation under anesthesia. So it's very painful. So what we do is a combination of interscalene, just to take care of the acute pain once the patient wakes up from a short general anesthesia, and the shack block to take care of a long-term pain with a depomedrol pivot. So it is giving us very good results, and patient can do like literally having a good moment the moment they wake up.
Dr. Amit, it is for you. How much blood pressure do you want from us in your beach chair positions?
So that used to be a struggle till about 5-6 years ago till we met Anshuman. So 90 to 100 is the systolic that we look at. The pressure basically from our own, kind of machine, not more than about 40 to 50 or so. Prior to that, we have had a lot of, not a lot of, but we have had incidences when there's been, breast swelling in females and stuff like that, because you need to maintain an increased pressure intra-articularly if you don't have a good hypotensive anesthesia. But things have really changed with him around.
So, Dr. Sandeep, do you put arterial in for beach chair position? Not always. In sicker patient?
Sick patients, yes.
Okay. Thank you. So, now this is the story of, you must be knowing him. He is Adam Hadjic. This slide is repeated from the last, this Yatharth Khan. He met with an accident on 11th August 2022 during sports. He was diagnosed as a rotator cuff injury. He was planned for the surgery. He had to choose his anesthesia, and his answer was block by the person who routinely gives this block. So he chooses his trainee. So he received intestinal block with a catheter by his fellow, and he was fully awake during the surgery. So what was his experience? His experience was, if I had to walk into this, I had walked into surgery at 8 a.m. and by 10 a.m. I was out again in my car, being driven to the shopping mall to do some cloth shopping, and that is the easiest time to do shopping according to him. That evening, we received guests from overseas, and the following day, catheter in place and are mobilized. I joined them on a sightseeing trip for New York. If I had to do it again, would I choose the same technique for anesthesia? Thank you.
May I request Dr. Divesh and Dr. Sandeep to kindly help us felicitate our panelists. Dr. Sandeep, to kindly hand over a memento to Dr. Amitnath Mishra. Yes. And Dr. Divesh to Dr. Pradeep. Thank you, sir. Thank you, Dr. Pradeep. Can I have the slide for the next session? Panel discussion on thoracic surgery. For this session, we have with us our speaker, Dr. Neeta D'Souza. She's a consultant anesthesiologist from Ruby Hall Clinic, Pune. Ma'am's area of expertise is regional anesthesia and pain management. She's also a BLS, ACLS, and ATLS instructor. She has extensive experience in teaching and training postgraduate students and postdoctoral students cadaveric anesthesia techniques. To moderate this session, we have with us Dr. Anirban Roy. Sir is senior consultant anesthesiologist from Sir Gangaram Hospital. His area of expertise is liver transplant, anesthesia for vascular, endovascular, thoracic surgeries, and perioperative sonography. May I also request the other panelists to kindly take their seats. Dr. Sandeep Diwan for the cadaveric insights, Dr. Sumit Goyal, Director and Head Neurosurgery, Group Director of Neurointervention, Yatharth Hospital. Dr. Parveen Mendiratta, Director and Head Orthopedics and Joint Replacement from Yatharth Super Speciality Hospital, Greater Noida. Dr. Saurabh Kumar Gupta, Director and Head Plastic, Aesthetic and Reconstructive Surgery, Yatharth Super Speciality Hospital. May I also request Dr. Pradeep to kindly be seated on the dais. Rizwan here, Dr. Mohammed Rizwan. Dr. Mohammed Rizwan, Senior Physiotherapist, Yatharth Hospital.
Good to start. A very good afternoon. It is usually a challenge to keep people awake in the afternoon. So if I start off saying that I may be interacting and asking questions to you all, probably it will keep you all awake. So at the outset, I am really thankful to Yatharth Group, Dr. Anshuman, Dr. Sandeep Diwan, to have given me this opportunity to be amidst you all and share my knowledge or the experience that I have gained. With regards to Jayashree Sood ma'am, it was a very emotional time because 20 years back, I had gone to attend her clinics, and I felt very thankful because very few teachers actually call you, teach you the way it should be done. And it has gone a long way in the impact that teaching makes one learn better, and it has done so for me. So fond memories of my stay back at trauma center, and we did a lot of thoracic trauma, so I'll share my experience on that. And Dr. Anshuman gave me this topic of Karna's Kavach, so it made me read up mythology to know Kavach kahan tak hai. So I may not cover the entire Kavach, in a sense covering the abdomen, which is somebody else's topic. So this is what I gathered, and I will primarily cover the thorax. Again, I've not kept a lot of literature review, but important tips and tricks and pearls that probably will help you achieve near complete analgesia. So just an overview that I'm not going to teach anatomy, but it is the step forward for understanding anatomy first, and then one knows what all needs to be blocked and how in a safe way. So first a little bit on anatomy, and of course the gold standard, which is still the paravertebral block, and the blocks around it. So coming to the anatomy, the nerve supply of the thorax, it's primarily the intercostals, we're aware. It's from the T1 to T12, and the importance of this slide, it's from the article in the journal Anesthesia in 2016. I need you to just keep in mind all these muscles. So the external being the serratus, the external intercostal, the internal intercostal, the innermost intercostal, just to note, it does not reach the sternum. And this small slip of muscle over here, which is the sternum, this is the sternum and this is the posterior part, which is the vertebra. So this is the transversus thoracis muscle, which has importance in the parasternal blocks as well. So is it enough knowing the anatomy and the course of the thoracic nerve or the intercostal nerves, which we know travel into the anterior and the lateral cutaneous nerve? So I would say the talk is pretty much complete if I tell you wherever the trauma in the chest wall is, be proximal to it. Okay, so this is the main aim of the entire what to block, right? Now, of course, if this involves the chest, obviously when we talk about breast, which is again a part of the anterolateral and the medial chest wall, it involves few other nerves. So it's not just the intercostals, but it is also the supply from the superficial cervical plexus, the brachial plexus, and of course the T2 intercostal, which plays a very important role in breast surgery. So the supraclavicular nerves, the intercostal brachial, which I said, the T2, which is a sensory nerve. Now these nerves, like the long thoracic, the thoracodorsal, again, which is a part of the brachial plexus, do they need to be blocked for analgesia is another important question. And if they are blocked, being motor nerves, does it have any implication? So this would primarily summarize all the different blocks that are given till date for thoracic wall analgesia. So anteriorly, when I showed you the first diagram, anything up to the mid-axillary line, or anteriorly, I would say the mid-clavicular line, and from the midline to the mid-clavicular line would be the anterior blocks. So that would be interpectoral, between the two pectoral muscles, the pectus serratus between the pectoralis minor and the serratus, parasternal, the superficial as well as the deep block. The deep one is also called as the transverse thoracic muscle plane block. The serratus muscle block, which is again superficial and deep depending upon the deposition of the local anesthetic. And if it's only for a single rib, probably intercostal nerve block. But as I said, we need to go proximal in the nerve pathway to the fracture. Coming to the posterior wall blocks, the gold standard for most would be the paravertebral, but it's not always easy. It needs a level of expertise and practice. Intercostal blocks, the retrolaminar, along the paravertebral are a lot of proxy blocks, which are similar to the paravertebral, but again, take time to act. So the intertransverse plane block, the midpoint transverse process to pleura block, erector spinae block, which is a level 1 block and can be easily performed. The paraspinal intercostal plane block, the rhomboid intercostal subserratus plane block. So every conference I attend, there is one more block added because the location changes by a centimeter or so. So just to highlight on the anatomy of the thoracic paravertebral. In 2021, we actually got to know more about the paravertebral space. So the teachings which I had probably as a resident when I started doing thoracic paravertebrals was pretty much the landmark guided. We didn't use so much of ultrasound. And the loss of resistance to the superior costotransverse ligament, which is not as perceived on an epidural loss of resistance, it's a little lesser. But to gauge that understanding and to get that expertise and the region of analgesia, so probably the understanding was even if it was above the superior costotransverse ligament, still it would have worked. And why? Because updated knowledge says that the superior costotransverse ligament actually has slits in it. It's not a continuous ligament. So when we're giving other blocks which are above or more superficial to it, we rely on the porosity of that area for it to be absorbed and go to the paravertebral space. But the modern anatomy micro-CTs, as you will see in the next image, as you can see, there are medial slit, lateral slit, and the intercostal muscles when the nerve travels out. So even if the local anesthetic is given above the superior costotransverse ligament as a part of the paravertebral block in a 3D micro-CT, it showed that it again had access and local anesthetic traveling towards the paravertebral space. So the paravertebral space is right here in blue. We often give this intervertebral space, the local anesthetic does travel there. So this green is the retro-superior costotransverse space, which is a good thing in our armamentarium to know that blocks, local anesthetic given there would definitely act. Now coming to the dermatomal distribution of thorax. This is there from our anatomy days of reading books of Chaurasia. Now this is okay, but the anatomy within, between the muscles, has pretty much changed because of modern cadaveric studies. Now if I say in thorax, other than for rib fractures, the bone pain is not so much, like for breast, like for oncosurgery. It's not that the ribs are broken in oncosurgery or for a thoracic tumor. So dermatomal pain is pretty much important, but visceral pain also matters, especially where there is bone involvement or visceral involvement. Excuse me. Now coming to where are paravertebral blocks used. So primarily for breast, thoracic surgery, upper abdomen, nephrectomies, and rib fractures. Excuse me. So this study done by Amit Pava, it just shows the different approaches to the paravertebral space, which is made much simpler by actually seeing the drug spread, sorry, by actually seeing the drug spread and the pleura actually being displaced down. So probably this can be better learned and studied in the workshop tomorrow. Another important thing which I spoke about, the retrolaminar block. Over here, they noted that a single retrolaminar did cover around 5 to 6 spaces, both cranial as well as caudate. Now so these are the proxy blocks, I would say, in and around the paravertebral space. So the rectus spinae block. Now one needs to know when it is involving the upper thoracic, the middle thoracic, as well as the lower thoracic. One needs to know, am I going to see trapezius throughout? Am I going to see the rhomboid throughout? And what are the muscles you actually see? So one needs to know the trapezius probably is there till T12, rhomboid till T5, it thins out at T6. So when you're giving blocks, these muscles need to be identified. Again, coming to the mid-transverse process block, it's exactly the midpoint between the posterior border of the transverse process and the pleura. This again, because of the newer anatomic insight of the micro-CT scans, the drug spread is pretty much consistent with a paravertebral block. The retrolaminar block, again targeting the somewhat similar to the ESP block, but a little more medial because the drug is deposited over the lamina. And of course, the facial plane block between the rhomboids and the intercostal muscles, which is often used for rib fractures. Now, coming to breast surgery. As I said, breast surgery, often you will see people are doing studies on comparison between a paravertebral and a pectoral block. But if you see the image, the area which a paravertebral covers versus what a interpectoral or a pectoral serratus covers is totally different. So it's not right to actually compare these two blocks because we know outright one is more superior than the other. So the area in green is primarily covered by the paravertebral. So with regards to breast surgery, one needs to know in which area the surgery is. If the lesion or the mass is restricted to the upper outer quadrant, the pectoral block works really well. But if the extent, like a phylloids or some extensive mass which needs a flap, comes very close to the midline, one may need to supplement with parasternal blocks as well. Again, lesions below the clavicle may need the superficial cervical plexus to cover the supraclavicular nerves. So, in breast surgery, what is the recipe if you ask? It is primarily the incision, location, where is the lesion, and very rightly said, talking to the surgeon. Ki, where is your incision going to lie? And I won't rest it at this. I would say you have to talk to the patient. Each one's threshold is not the same. I have met, probably I work with 5-6 different breast surgeons. So 2 are of the opinion, breast surgery, pain nahi hota hai. Okay, wo painkillers se manage kar lenge. But there are some who are very sensitive. The moment they are extubated, they start crying. So it depends on multiple factors. Before, in the pre-anesthetic checkup, I would definitely say assess the pain threshold of the patient. You can compare it to the worst pain they've experienced till date and what have they taken for that. Again, it's very important to know whether there is axillary dissection. Because as I said, the axilla is not very well covered with any level paravertebral. So if it's T2, supposedly axilla is covered better. But the elements of the brachial plexus supplying the axilla are way more. So one needs to cover the lateral and medial pectoral as well as the T2 intercostobrachial nerve. Again, as I said, the surgeon, it's a SOS flap. So some flap surgeries, if they have perforator flaps and the perforator is somewhere in the mid-axillary line, they may not allow you to needle anywhere there because it's a rotatory flap. The blood supply can get compromised. So you have to change your plan of analgesia. Again, as I said, the T2 coverage, one option is LIA, which is a local infiltration along the line of incision where the axillary incision would be. Now, there are studies to say that the superficial serratus plane block, if given in adequate volumes, will cover the T2, but it is yet to be substantiated. But there is evidence to state good volumes in the superficial serratus plane does cover T2. And of course, we know that these are all facial plane blocks. So we look out for some vessels, like if it is in the interpectoral, we look out for the pectoral branch of the thoracoacromial artery, because we know the neurovascular plane is the right plane. Similarly, when we are talking about the superficial serratus plane block, we can look for the thoracodorsal vessels. So that is important to use Doppler prior to the block, and these blocks require lot of volume. Coming to this, we all have known the prospect studies, which in the 4 years back stated that if you can see the red box, just focus on that, because we know minor breast is taken care by a lot of other multimodal analgesic techniques of IV. But the important part being paravertebral is grade A, and PEX block if no axillary node dissection, or if paravertebral is contraindicated is grade A, and of course LIA. So all these are grade A, so which states that definitely they provide benefit. But they also mention what is not recommended for onco. As I said, one size does not fit all. So sabko ESP deke kaam ho jayega is not the, some odd cases, if the level of experience is not there, probably you may give a erector spinal block. But what does the study say? There is limited procedure specific evidence. Now this is like for 5 years back. So there are studies which say that yes, 30-40% pain relief hua hai. So it depends on the level of expertise at your setup. So you should provide something versus nothing. So this, as they said, these are all limited procedure specific evidence. Even the transversus thoracic muscle plane block, which is the deeper parasternal block. Same thing, there is another perspective in the prospect guidelines. So if I just simply tell you, these are the different anatomical involvement. And if you see the ticks, the maximum ticks are covered in paravertebral block and reasonably in PEC2 block. So as we can understand, a paravertebral with a pector serratus, the pec 2 is what? It is pec 1 plus pector serratus, right? Terminology, I'll keep it simple. I don't want to call it pec 2 alone because it involves interpectoral plus pector serratus. So these two are the blocks which give maximum coverage for the breast. And again, to remember, these colorful zones, yes, 2 minutes more. So these colorful zones actually tell you which other areas also need to be covered. Now coming to the facial pain blocks of the chest, just to remember, use of color Doppler in the, before the plain blocks are given, identifying the pleura. Wherever there is a pleura, it is better to target going to the rib so that you don't inadvertently cause a pneumothorax. Because the common complications are pneumothorax apart from last because huge volumes are involved. Coming to this, the same thing I have reinforced, that the blocks which cover most of this, now just imagine the number of things to be blocked. As I said, the long thoracic and the thoracodorsal, they are actually motor nerves. But if I'm doing a LD flap, that LD flap, there is a lot of pull and stretch, so possibly blocking it would be a better option. But it's not necessary for pain relief. So I'm not going through these studies, but sufficient is done on comparison for breast analgesia. Quickly covering an important topic, which is thoracic trauma. The crux is the location of trauma. If it's an anterior rib fracture, serratus plain blocks work really well. Superficial, deep. This can also qualify for an on-arrival block. If I go locate the third rib in the mid-axillary line and give around 20 to 30 ml of an analgesic dose of say ropivacaine 0.2, it will give you a huge anterolateral coverage of analgesia. Then again, see the score of the patient. I'll mention few scores here on the next few slides. If it's a single rib, it's simpler. You can just target an intercostal nerve to that rib. But you have to remember proximal in the course of the intercostal nerve. Aim is to be proximal to the site of fracture. Feasibility of a catheter depending on the pain score. If it's multiple rib fractures, giving a single shot is no help because the respiratory mechanics will fall after that. So there are certain criteria such as the sequential clinical assessment of the respiratory function to see what is the respiratory rate, what is the saturation, what are the number of ribs fractured, okay? Is the patient able to cough? Because then there will be a lot of atelectasis otherwise. So the scoring is done on this as well. There's something called as a stumble battle score, which again gives you higher the score, you need to give these patients long-term pain relief. So I would say multiple rib fractures, if no anticoagulation issues, an epidural is the way forward because we can retain it for 6 to 7 days. Or else facial plane catheters more proximal to the injury. If they are posterior rib fractures, you may actually have to put even erector spiny plane catheters would be an option. Now thoracoscopy, thoracotomy quickly. All these which I mentioned on the screen are the possible analgesic techniques. But coming to, in our setup, we do a lot of medical thoracoscopy through a single port. And it's an anterolateral aspect of the chest. So even if you give a deep serratus plain block, it does well, okay? A lot of times patients with ICDs require certain pain relief, and that is quite a lot underestimated, and the patient doesn't breathe well. So this block can be given even in the ward with basic monitoring techniques. Spine surgery, again, these are the primary blocks which are given. The erector spiny plane block, again a level 1 block, very simple to follow, very simple to perform. But one should know upper in the thorax, which are the muscles involved. Like when I talk about the T-lip block, it's a little lower part of the kavach behind the lumbar area. So coming to the current consensus, the mechanism still remains controversial. It has failed to demonstrate consistent spread to the ventral rami of the intercostal nerves. And of course, the biggest risk is last. So that needs to be taken care of. To prolong analgesia, use of dexmedetomidine and dexa is the way forward when we don't want catheters. So take home, know the anatomy, variations, know about the surgery. What is the plan? Skill set acquisition, so attending conferences like these, getting new insight, getting experience, getting mentors to guide. Pain rounds, assessment of scores, severity, very important. So no single one regional anesthesia technique solves or gives all analgesic cover. So thank you for your patient listening, leaving you with a sound knowledge, making the armor close to near perfect. I wouldn't say complete. Thank you.
Thank you, ma'am. May I request Dr. Anirban to kindly take the stage now to moderate the discussion further, and also request Dr. Hital Vadera to kindly join ma'am for the panel discussion. We will be serving tea right here in the hall so that we can push right ahead with our further panel discussions. Neeta ma'am to kindly be on the stage, ma'am. Anirban sir to be on the dais.
Okay. ऑटोमेटिक नहीं होता क्या?
नहीं ये अभी क्यों इतना ये कर रहे हैं? तो गया मेरा क्या हुआ कितने का? इसमें आएगा आ गया अब आएगा.
First of all, thank you very much for giving me an opportunity to stand in front of you. And I bring my heartful shirt from Gangaram Hospital. And thank you, Dr. Nita, for your elaborate discussion on the topic. And made us think block very simple and understandable. May I know the audience, how much of you are using the thoracic interfacial plane blocks? Can I show your, raise your hands? Very few. Okay. So hopefully after this discussion we will be able to do more number of interfacial plane blocks in your practice. So with our panel, first of all, I will ask to address the issue of breast surgery first, because majority of the interfacial plane blocks is concerned to the breast surgeon only. So first of all, I will ask Dr. Praveen. He is head of the department of breast oncosurgery at in this hospital, Yatharth Hospital only. Sir, how much of your patients are using you are using the interfacial plane block in your cases?
Sir, in complete breast removal, means modified radical mastectomy, we use facial planes like serratus as well as interpectoral. But T2 intercostal brachial we don't prefer because we cut further at the time of dissection. And in breast conservation, T2 we can use and interpectoral also. We are regularly using at Yatharth Hospital, Greater Noida as well as Noida 110 Center.
Okay, sir. So in simpler operations, you don't use any interfacial plane blocks?
No, sir. In breast surgery, we prefer to use T2.
I'm asking about suppose superficial operation, you are doing breast conservative surgery,
right?
With lumpectomy,
only lumpectomy we don't prefer.
Lumpectomy is simple reconstruction we don't use. Modified hysterectomy or some
breast conservative surgery or axillary lymph node dissection we used to prefer.
Okay, sir. Coming to Dr. Saurabh. Sir, you must be using a lot of breast reconstructions and some aesthetic operations also.
Yes, sir.
In the aesthetic operations, sometimes you use this kind of expanders.
Yes, definitely.
So do you think this kind of operation needed more
and will this a requirement as compared to the modified hysterectomy and
So
subreconstruction?
definitely, because as you see that in those cases where the mastectomy has been done, the tissue is taken out from the body. In these cases, we put some expansile tissue expanders or the implants inside, so it gives a more discomfort feeling post-op. So we need better blocks in these cases, or the blocks which definitely just bring down the sensation of the expansion. Yes.
So as compared to other reconstructive procedure, this kind of procedure you feel the pain is more as compared
Yeah,
to?
definitely, because expansive pain is like, it's really difficult.
So what do you think in the next post-op round, we are using blocks inside patients?
Yes, we are using some blocks in these cases.
So what function you exactly see in the post-operative period to see this group of patients doing better as compared
Yes,
to?
definitely the patients which are given blocks, they are doing better and they complain of less pain as compared to the patients in which the blocks are not used.
Better in instead of pain or some kind of shoulder mobility or overall?
Everything overall. The
Overall quality.
Yes, the shoulder movement and the discomfort sensation, they are better.
Okay, sir.
Indeed.
So coming to Dr. Praveen, do you prefer, sir, a pre-operative, pre-procedure block or
It is a pre-procedure block which is better, sir, what I feel.
Okay, so both of the.
After that completion of operation, we prefer to give local line of incision, line of block, sir. Local infiltration with ropivacaine, non-ropivacaine.
After surgery?
After surgery also, in complete removal as well.
Sometimes surgeons ask, encounter difficult amount of problem known as interference with the electrocautery. Do you have any issue with this?
Yes, sir. There is sometime there is local infiltration cause edema to that place, and whenever we cauterize that plane, there is diffuse edema in presence of water or some local anesthetic. Our monopolar cautery will not do good, but our bipolar will do good. It is the surgeon preference. If we use bipolar at that time, the effect is very, very good.
We want this kind of surgeon in our team actually. Because we allow all the block, we can do everything. Thank you, Dr. Praveen. So, do you, regarding pre-block, do you think any issue with the tumor progression or oncologically?
No, sir. Oncology, there is no concern regarding the nerve, unless until there is gross tumor infiltration to that area or local lymphatic spread or lymph node to that area. Suppose we are giving T2 and there is multiple conglomerated nodes are there, then definitely it would interfere, otherwise not.
Okay. Thank you so much. And talking about shoulder mobility, do you think your patient, when you cut the intercostal brachial nerve or some axillary dissection, this patient have some shoulder mobility issues in the postoperative?
We prescribe aggressive physiotherapy to first postoperative day, and that is possible because we had given pre-operatively blocks.
So coming to Dr. Rizwan, you must be doing a lot of physiotherapy with Dr. Praveen. So what is your experience about comparison the patient without block and with block? How do you?
Like if I explain in my experience, like if I put on a point of pain, once I deal with such kind of patient like breast cancer patient or something like. So in that case, particularly, they affect the surrounding area. If I'm talking about the shoulder, and if they affect the long thoracic nerve, so they get winging of scapula.
Okay.
So in that case, we are more focused over the affected nerve, like long thoracic nerve, if they get affected because of blocking and something like this. So we have to deal with this also. Like surgeons are doing the surgery for the cancer, breast cancer, but we have to deal with the shoulder and with the scapula, which is affected by the long thoracic nerve.
So you don't want any block that should interfere with the long thoracic nerve?
Yeah, definitely, because they expand the treatment area and approach. And we have to change the protocol also. Generally, we just go with the patient, like this patient is breast cancer, okay, surgery is done, everything is good. Generally, we focus over the pectoral muscles because it is very common to get contract and that limit your shoulder movement. Patient can't erect the shoulder, can lift it, and that weaken the muscles. But if the plus one, like if they affect the long thoracic nerve, then you have to work on the posterior aspect also. The surgery done on the anterior part, but you have to deal with the posterior because they affect the scapula, and the scapula is a major part of the shoulder joint. So there is a complete complete rehab included the surgery area plus the surrounding structure, and because there's a nearby the shoulder joint and the muscle is a common area, that we have to deal the shoulder rehab plus scapula and the surgery part.
Great. Thank you for your experience. Coming to Neeta ma'am. Ma'am, from presentation I could understand your go-through block is paravertebral before breast surgery.
So just 3 days back, we had a patient with heart failure. I wouldn't say it is the way forward for every patient, but in the last 6 months, we've done 8 patients for awake breast. So it has to be very selective. Patient has to be cooperative. There are some patients who table se bhag ke jaane ke liye ready hai. So I can't force or pin them down, although we have remifentanil. So patient counseling very important in certain factors. Ki GA is very high risk, ventilator pe jayenge. So we had a patient with heart failure, triple vessel disease, huge advanced with metastasis involving lungs. So these patients, my go-to is paravertebral with interpectoral pectoserratus. But patient should be willing for 5-6 small injections.
Okay.
So all this is important.
Other than this, what is your routine practice after your breast surgery?
So,
like MRM, simple, MRM is very common, no? So for moderate reconstruction.
So routine practice, as I said, MRM, just to comment, pre-op, post-op blocks ke bare mein you were just asking. Pre-op, there are, as I said, we work with different surgeons. Some don't like the local anesthetic in their
They
field.
don't like pre-blocks.
So I use a lot of magnesium sulfate, like 40 milligram per kg, that takes care of intra-op requirement. With regards to overall general anesthetic, reduction in the overall requirement. So that holds good for intra-op. So we've got used to giving post-op blocks.
Okay.
And of course, the 3-4 hours we reduce on, we kind of lose out on those 3-4 hours of analgesia when giving it pre-op. And there are options to give intra-op. So although I would have preferred giving it pre-op, but single shot don't last long. So I would prefer to, like, give it post-op where it lasts. And now the final decision is done. उन्होंने flap किया है, तो I can cater and decide. I don't want कि आपके block के वजह से हमारा flap को कुछ हो गया. So their decision is done, and I stay away from there. Implants like these, they don't want us to go and poke that implant. So obviously there will be a note of caution. With regards to what Dr. Rizwan mentioned, ki shoulder movement. So certain novices use a lot of local anesthetic which tracks to the brachial plexus, and we've noted numb hands, and the shoulder movement is also gone. So the blocks, very limited volume, especially in the interpectoral, which targets the lateral and medial pectoral nerves. The volume should be limited, like to almost 10 ml or so. So that is extremely important.
So most of the surgeons I encounter, mostly they like the posterior blocks, ESP and paravertebral. They don't want to interfere in the anterior part, anterior chest wall blocks, and except Dr. Praveen. So he has for every block. The question for Hetal sir. Sir, do you recommend catheters, ESP or paravertebral in breast surgery? What is your opinion about it?
Actually speaking, in breast surgery, pain part is for, I will say, first 24 hours only. So most of the times you don't require any catheters if you start other analgesic at proper time. Because if there is breakthrough pain, then patient will have a lots of pain. So we have to start multimodal analgesia. Suppose if you are giving paravertebral block, at the same time you give NSAID, you give paracetamol. And then, as Madam said, you can add magnesium sulfate also, so that once effect of block wear off, you will have an effect by other NSAIDs. Even we prefer to give dexamethasone IV to all the patient. It helps to reduce the, prolong the effect of the block a bit, as well as it will help to reduce the inflammation, so that pain part will be covered in the post-operative period also.
Excellent, sir. Thank you so much, sir. So we are running out of time. The second thing is the reef fractures. This is Dr. Rizwan. How frequently you are encountering reef fracture patients for rehab in the post-operative period?
Like in case of rib fracture, first we have to take care the area of involvement Either this is a simple rift fracture or they interrupt with the lungs functions, because we have to take care of the lung compliance. The major issue is like that. Bones is healing by its own. So we just have to support the bones, but we have to deal with the lung compliance first and prevent any pulmonary complications for the patients. This is the primary word. And basically guide the patients how to breathe without pain and effectively. Because if I'm talking about a particular surgery like CABG, the sternum get involved in incision in this area, rift fracture, the generally patient have a fear of cough.
Yeah. Okay. Cough is a very important factor,
Very, very important, because they have fear of coughing or sneeze. So they thought if we cough, the pain will start. We need a medicine for that. So we teach the patient after surgery, we taught the patient for supporting coughing, so that clear the lungs without affecting their breathing pattern. There are a lot of techniques to active and passive both to make airway clearance and improve the lung compliance.
Just interrupt you. So do you think, as Madam said, thoracic epidural is gold standard for everything? We are in our hospital, we have mostly we use thoracic epidural only. Interfacial pain blocks comes as a backup. If any problem, technical difficulty, anticoagulants, you use this thing. So if you compare the quality of analgesia, I think Dr. Nita and Dr. Hetal will agree, the amount of analgesia, the depth of analgesia is less as compared to epidural as compared to the other interfacial pain blocks. So as per your opinion, as we are saying, the fear of cough is the important factor as compared to the actual pain. So if the quality of analgesia goes little bit down also, but if they can effectively cough, then your job is done, right?
Yes, sir. Initially first, like if I say the first day of the surgery, initial first 24 hours or 12 hours.
This is a fracture only.
Fracture. The supported and patient can come give anesthesia for pain relief and so on. So the first 12 hours, like when is going on, the medicine going on, the patient is feel much comfortable, but in a longer way, because bone is not getting healed in one day. It will take a time. So during that bad days, a patient is in bed, a patient is on a hospital. So during that phase, we are more focused on the pain-free breathing patterns, and as a limited of patients, you can say without fear, the patient can breathe and exert the cough and what are the need for the patients. Yes.
Thank you so much. The effective is go clearance basically. So coming to the third part is the facial pain blocks for this thing, spine. Dr. Sumit, how do you are doing spine surgery for a long time? We are together in Gangaram Hospital. So at that time there is no interfacial pain blocks for spine. How frequently your anesthesia is blocking your spine patients?
So of late we since I joined Yatharth, so we have a dedicated team who is doing this. So they are putting pre-operative interfacial plane blocks, rectus spinae and other. Yeah, I totally agree. We were not doing it on Gangaram days.
No, we are doing now, but our days nothing was there. Only intrathecal morphine was there. Sometimes people were sleepy after the operation for a long time.
Yeah, so
but now they are waking up very frequently.
So now we are using it, and we are pretty happy with the post-op phase. So we are able to ambulate our patients better because the muscle spasm and all is relatively less, and I think that serves a purpose. Post-spine surgery, we want an early ambulation, and this does help.
So all surgeries you are using, any decompression, laminectomies, or your big fixations?
Largely when we are having a long incision, mainly the fixation and or a long segment decompression. For microdissectomies and all, we are not doing it. Or if you are using doing some MIS, then also we are not using it. But if you are basically a long incision, lot of paravertebral dissections and long segment fixations.
We are getting good result in basically kyphus quality correction. The big long incisions, and we do have the awake surgery also sometimes. Okay, they are very good help, erectospinal, and mostly we are doing erectospinal plane blocks in the hospital. And modified TLIP and TLIP can also be used. Last question to Dr. Hetal. Sir, how much you have done? I have seen your YouTube video long time back.
Yeah.
I think a Facebook video. I think.
Yeah.
You are doing landmark guided this thing spine blocks for the thing.
So how much volume do you use in such patients and the use of catheters in ESP?
You mean for erector spiny block?
Sir, for spine surgeries.
Yeah, for spine surgery depends on the incision. Like suppose it is for 1 or 2 level decompression, then 10 ml on each side is enough, like 0.2% ropivacaine, 10 ml on each side is enough. But sometimes like for scoliosis surgery, you require a higher volume. So depends on patient's weight, we calculate the toxic dose of the drug and then we dilute the drug according. Sometimes even we give 0.1% on 0.15% ropivacaine and we try to give larger volume. Like for scoliosis surgery, we have given 50 to 60 ml total on both sides, like 30 plus 30 or 25 plus 25, and it works well.
Thank you so much, sir. Last question on final thing, because most of them are not raising hand for this thing, for blocks.
Yeah.
So thoracic paravertebral block is little difficult ultrasonography because it is a deeper block and it comes to the neuroaxis. So it needs little more training to reach the paravertebral block. So what is your suggestion for the new trainees? How to progress to paravertebral space? Any suggestion from both of you, Dr. Nita and Dr. Hetal, please?
Yeah,
How to progress?
actually speaking, Anirban rightly said that it is a deeper block, it is bit difficult block, you are close to pleura. So you are always worried about what if I puncture the pleura and what if patient has pneumothorax. So if you consider certain things, like if when you are giving ultrasound guided blocks, always look for the needle tip while giving the block. So better to go for transverse approach rather than giving parasagittal approach if you are beginner. Second thing is always if you are not able to look at look at the needle tip, then do hydrodissection. Third point is always attach syringe to your extension tubing while locating the space. So even if you accidentally puncture the pleura, there won't be sucking of air while inspiration. So even if you puncture the pleura, there won't be a big pneumothorax, and most of the time you will be saved. So if you keep this thing in mind, you can give paravertebral block very safely. Nita ma'am from here.
When I was doing my residency, I have not given a single paravertebral. So I think I would suggest...
Same here with me also.
I would suggest you have to attend cadaveric workshops, have an insight into how the space looks, try it on that. The feel is important. Even till date, I use my landmark technique. I mark the point, and then I use ultrasound to show the fellows that, see, the pleura is moving. So it's no harm in using your conventional landmark guided techniques. So I still use a TUHI. I place at T4, I place a catheter, but I see the pleura moving and it's kind of assisted, USG assisted. Because in this era of ultrasound, it doesn't make sense in not using ultrasound for safety. But doing a lot of workshops like this one, like tomorrow when you're on the station, actually going and identifying the superior costotransverse ligament in all different planes. So a lot of, you have to make use of these resources, not only videos, hands-on makes a huge difference. Another important point I would say is wherever thoracic surgeries take place, we have a lot of onco-thoracic cases which take place. Udhar to ICD hai hi, udhar try karne mein kuch harm nahi hai. So try it out in those cases where you can and when you are not fearful. See, a needle pneumothorax is not going to cause some huge thing, like it's not going to cause a pneumothorax or a tension pneumothorax. But it's safe to use on try in these patients who have an ICD for whatever reason. Even if you're giving an ESP, go ahead, give one single plane, a single shot, 20 ml, so that also works well. So somewhere the learning curve has to move a little ahead.
Thank you so much, ma'am. For the sake of time, we have incorporated thoracic surgery procedure along the fracture only. So thank you so much for your, thank you so much.
Thank you for that excellent discussion. May I request Dr. Nita and Dr. Yetal to kindly help us felicitate our panelists, Dr. Sumit Goel, Dr. Saurabh Gupta, Dr. Praveen, and Dr. Rizwan, as well as Dr. Anirban Roy. Dr. Sumit, please. Dr. Saurabh, Dr. Rizwan, Dr. Anirban, please. Dr. Praveen. And Dr. Anirban. Thank you, everybody. For the next session, the Pandora's Box, we have with us our speaker, Dr. Hetal Vadera. Sir is head Department of Anesthesia from Sterling Hospital, Rajkot. His areas of expertise being regional anesthesia, neuroanesthesia, bariatric anesthesia, and he has a special interest in creating awareness about CPR. To moderate the session, may I request Dr. Anil Sharma to kindly come to the dais. Dr. Anil is a senior consultant, anesthesiology from Apollo Hospital, New Delhi. His areas of interest include transplant, oncology, robotic anesthesia, and of course, USRA.
क्या करना है? Yeah.
May I request the other panelists also to kindly take their seats on the dais. Dr. Sandeep Devan for the cadaveric insights. Dr. Mohib Hamidi, senior consultant and head robotic surgeon, general surgery and laparoscopic surgery, Yatharth Super Speciality Hospital, Greater Noida. Dr. Neelam Banerjee, senior consultant and robotic surgeon, head of IVF and fertility, Yatharth Super Speciality Hospital, Greater Noida. Dr. Manoj Gupta, senior director and head Department of Robotic and Lap Surgery, GI Oncology and Liver Transplant. And Dr. Mohammad Rizwan from Physiotherapy.
Shall I start? Yeah.
Dr. Hamidi, Dr. Neelam Banerjee, Dr. Manoj, and Dr. Rizwan. Over to you, Dr. Vadera.
Thank you very much and good afternoon to all of you. At the outset, I would like to thank Dr. Anshuman and Team Yatharth for inviting me here for this workshop. And I would like to congratulate entire team for organizing this wonderful workshop. So, Anshuman has given me a topic which needs a day to cover the complete topic, but I am giving just 15 minutes. So I will try to finish it in 15 minutes, but give it 2-3 minutes more. So when I was given this topic and then when I put to, Gemini, it prepared this video. So it is a Pandora's box, and every month you will find a new block coming out, and people are injecting 1 centimeter lateral or 1 centimeter medial or 1 centimeter cranial, and there is new block. So there are lots of block for abdomen as well as thoracic surgery, as Nita ma'am said. So myself, Dr. Hetal Vadera, I am coming from Rajkot. I am bringing greetings from my hospital. This is Sterling Hospital, Rajkot. So why Pandora's box? First question comes to our mind. So once opened, there are multiple options. It is to promise better analgesia to the patient, but in reality there is a confusion, there is an overlap of all these blocks. So important question before deciding the RA technique for abdominal surgeries, we have to understand the anatomy. Where is the incision? Whether we want to give somatic analgesia or visceral analgesia or both, and acceptance of complexity and risk of the block. So if you look at the anatomy, abdomen is supplied by T6 to T12 and L1. So T6 to T12 come out of the intercostal space, they travel into the plane between transverse abdominis and internal oblique muscle, and they supply the entire abdomen. Lateral cutaneous branches enter the abdomen T7 to T9 just below the costal margin, while in mid-axillary line T10 to T12. So after supplying the lateral part of the abdomen, anterior cutaneous branches enter just below the rectus abdominis muscle. So they supply midline of the abdomen. So if you look at this video, this is external oblique muscle. If I remove the muscle, we can see rectus abdominis and internal oblique muscle, and if I remove the internal oblique, you can see the nerves are entering in the plane between internal oblique and transverse abdominis muscle. Same way, posterior abdominal wall blocks, there are many abdominal wall blocks like QL 1, 2, 3, intramuscular QL. Nowadays they are called lateral, anterior, posterior QL, and they are used for abdominal surgery. Surgical incisions, as surgeons will agree that there are multiple incisions according to the type of surgery, and according to that we have to decide the block. As Nita madam said, even for abdominal surgery, even today, gold standard is epidural analgesia because it provides somatic as well as visceral pain relief. It is adjustable, like you can place catheter at T6 level or T8 level or T10 level, wherever you want. You can provide continuous analgesia. It is superior for open colorectal surgery, upper abdominal surgery, major oncological resection. But at the same time, there are limitations, like you cannot use it in patient on antiplatelets or anticoagulants. There are chances of hypotension. You require technical expertise, especially for thoracic epidurals. Failure rate is high even in the hands of the experts. So we are opening the Pandora's box of facial plane blocks. So if you look at this beautiful article recently published, these are various blocks for upper abdominal surgery, above umbilical surgery. So there are blocks like Bridma block, TEPA block, M-TEPA block, then subcostal TEP blocks and whatnot. So what is subcostal TEP block? It is basically deposit of the drug between rectus abdominis muscle. Here you can see this is rectus abdominis muscle and transverse. So you put the probe in the midline, you look at the rectus abdominis muscle, you go laterally, you find the transverse abdominis muscle, you deposit few ml of drug here, then go further laterally and you will find external oblique, internal oblique and transverse abdominis muscle, and you deposit another 10-15 ml of LA here, and you will block lateral cutaneous branches and you will give good analgesia for the subcostal incision. So this is the video which showing this is the rectus abdominis muscle, anterior rectus sheath, posterior rectus sheath. You can see now emergence of transverse abdominis muscle. So you deposit some drug here, 5 to 7 ml. This is the linea semilunaris, and you can see external oblique, internal oblique, and transverse abdominis muscle. So the 2 injection will take care of subcostal incisions. But nowadays you will find in last 5 years there are many blocks like modified Bridma block. Basically it is a deep serratus anterior plane block, which was described by madam in her presentation. It is effective for open and laparoscopic surgery. It is comparable or superior to, there is very small literature like few case studies or 1 or 2 RCT, but they say that it is better than subcostal tape. And continuous block can provide opioid sparing effect. So you have to deposit the drug at the level of 8th rib, while in thoracic surgery we deposit at 4th or 5th rib level. So there is functionally a low, it is a functionally a low deep serratus anterior plane block. So if you put the probe at the level of 8th rib, you can see this is the 8th rib, this is serratus anterior muscle, this is the latissimus dorsi muscle. If you deposit the drug here in this plane, it becomes your Bridma block, modified Bridma block. Then came the M-TEPA. TEPA block was depositing the drug between internal oblique and external oblique, as well as another injection between internal oblique and transverse abdominis at the level of 10th costal cartilage, and that is perichondrial injection. But in modified TEPA, there is single injection that is between internal oblique and transverse abdominis muscle. It blocks T7 to T11 lateral cutaneous branches. It is single deep injection, but it is a very high volume block. Like they say that you require 40 to 50 ml of LA. So analgesia analgesia comparable to external oblique intercostal block you find in open laparoscopic cholecystectomy, but and it is better than LA infiltration. It is high volume blocks. So you have to be careful, especially in frail patient, otherwise there will be local anesthetic systemic toxicity. So if you look at this image, this is the 10th rib. You can see this is external oblique muscle, internal oblique muscle, and transverse abdominis muscle. So if you deposit the drug here in this plane, it becomes your MTEPA, but you require higher volume so the drug spreads in the entire plane. External oblique intercostal plane block we showed in the morning session. It is between external oblique muscle and intercostal muscle at the level of 6th or 7th rib. You go little bit lateral to the mid-clavicular line and deposit the drug. It will block T6 to T10 and 11. You have to go a little bit laterally from cranial to caudal so the drug spreads and block the lateral cutaneous branches. You require 20 ml of LA. It is consistent. It has got consistent opioid sparing effect, and it is effective in open supraumbilical surgery and laparoscopic bariatric as well as hepatobiliary surgery. It shares a common facial continuum with SIPB. If you look at this, this is the 6th and 7th rib, and if you and this is the external oblique muscle. If you deposit the drug here, it becomes your external oblique intercostal plane block. So if you compare this above umbilical block, subcostal tap is similar to MTEPA. You are depositing the drug in similar plane, while Brilma is similar to external oblique intercostal. So they have got similar plane. Newer block shows more consistent analgesia than subcostal tap, which was earlier described. Best results seen when somatic pain predominates. When you are targeting visceral pain, you have to go for either paravertebral or epidural catheters. Choice should depend on surgical incision, patient factors, and operator familiarity. Below umbilical surgery, I will not go into detail because everybody knows about tap block. Tap block, you have to inject the drug between internal oblique and transverse abdominal. There are various variants like lateral, posterior, subcostal tap. According to the type of surgery, we can select, and we can deposit the drug in the plane between internal oblique and transverse abdominis muscle. We can use this block in cesarean section, appendectomy, inguinal hernia, and whatnot. A limitation is no visceral analgesia and limited cephalate spread. So if you inject the laterally, it won't spread to the subcostal area, and if you inject laterally, it will not go to the ilioinguinal iliohypogastric plane. So you require higher volumes to cover these things. We all know that this is the tap plane, and this is the most popular, I will say, abdominal wall block. Posterior tap block, you have to go a bit posterior. It is similar to initially described lumbar triangle of Petit injection. So if you go posteriorly, there are chances of spread of the blood in the thoracic paravertebral space similar to QL block. So it provides better analgesia as compared to lateral tap, and sometimes with higher volumes, it may spread into the thoracic paravertebral space and can provide some visceral analgesia as well. So clinical use, similar cesarean sectional hysterectomy, lower midline laparotomy, and as I said, it has got little bit longer duration as compared to lateral tap block. QL blocks, all QL blocks are attempt to push LA medially and cranially towards thoracic paravertebral. So basically QL blocks come into practice because we wanted visceral analgesia as well, because all these blocks are for somatic analgesia. So they develop various type of QL block that there is lateral QL, anterior QL, and posterior QL. That depends on the where you deposit the drug in relation to the QL muscle. If it is anterior to the QL, then anterior QL, lateral to the QL, lateral QL, and posterior to the QL is the posterior. So in lateral QL, you deposit the drug between transverse abdominis and lateral border of quadratus lumborum. Again, it is similar to the posterior tap, and it provides similar analgesia, so it is not of much advantage. Posterior QL, you deposit the drug between posterior to the QL and QL. It is between QL and posterior thoracolumbar fascia. It gives analgesia from T9 to T11. Again, I will say it is not that great, but if you want the best QL, I will say it is anterior QL, because chances of spread of the drug in the thoracic paravertebral block space is highest with this block, because anterior thoracolumbar fascia is connected to the thoracic paravertebral space through diaphragm. So it can provide some visceral analgesia, and studies also say that. But it is little bit technically demanding because you are too deep, and there is a risk of hypotension if drugs spread to the thoracic parietal space. And some of the studies say that it has got little slower onset as compared to other blocks. QL4 blocks is intramuscular QL. It is like injecting the drug in the QL muscle, but I am not very convinced with this block, so I will not go into the detail. So here you can see this is the thumb sign of the lumbar vertebra. Here there are extra-oblique, inter-oblique, and transverse abdominis muscle. This is the QL muscle. This is erector spinae psoas muscle. This is the transverse process, and this is the vertebral body. So if you deposit the drug at the lateral border, it is your lateral QL. If you go here, somewhere here, it becomes your posterior QL, and between psoas and QL, it becomes your anterior QL. Thoracic parietal block, I will skip entirely because Madam has covered it beautifully, but it is the block to provide the visceral analgesia if you don't want to give epidural. And erector spinae block is proxy block for thoracic parietal block, but I am not very much convinced with it. I use it extensively for spine surgery, but for abdominal surgery, results are not consistent. So key comparative insight, lateral tap is similar to posterior tap, QL1 is almost like tap, QL2 better than tap but not that great, while QL3 is the best, and thoracic parietal block is the block which provides visceral as well as somatic analgesia. So how to select the block? There is confusion. So it depends on where is the incision. So if it is pharischian incision, you can go for tap or posterior tap, inguinal tap or ilioinguinal now block, lower midline you can choose QL2 or QL3, pelvic surgery QL3 or ESPB you can use. For somatic versus visceral analgesia, as I said, for strong visceral pain, either you go for anterior QL or thoracic parietal block, but if you want only somatic analgesia, tap or posterior tap is enough. Acceptable complexity risk, as I said, QL or thoracic parietal block, they are most complex, so if you are beginner, don't go for it. You can use other block like tap or ESPB. If you compare it with epidural provides somatic as well as visceral pain, while facial pain blocks are good enough for somatic pain release only. They are, if you look at the reliability, epidural is highly reliable, while if you look at the ERAS-friendly option, then facial pain blocks are better. Surgery and incision, I have already blocked. Facial plane blocks in brief for laparoscopic and robotic surgery, they are good for laparoscopic and robotic surgery because we are targeting port side somatic pain mostly. Visceral pain is less in this surgery as compared to open surgery. That's why we can use these blocks for laparoscopic and robotic surgery. Ports pass through skin, muscle, and facial pain, and all these are covered by facial pain blocks. That's why they are good. They block somatic and nociception at tissue level, while epidural sometimes is overkill. For laparoscopic surgery, even I will say local infiltration with intraperitoneal instillation also works well. For common laparoscopic ports like paraumbilical region, we require tap or rectus sheath block. For multiple ports, we require bilateral tap and QL block, upper abdomen T6 to T9, so we have to go for subcostal tap or QL. Lower abdomen, we can go for tap or ilioinguinal block. So what FPBs do well in laparoscopy, they provide excellent port site analgesia, they reduce opioid requirement, they facilitate early ambulation because there is no motor effect which is seen in epidurals. They fits in ERAS pathway because there is no hypotension or no motor effect, and they have got low hemodynamic effect. So that's why they are preferred, but at the same time they don't take care of visceral pain which is taken care by epidurals. Shoulder pain is also not covered, so you have to give multiple analgesia, multimodal analgesia to cover all these aspects. So if we compare FBP to epidural and minimal invasive surgery, port pain is similarly covered, while visceral pain is better covered with epidural. At the same time, hypotension, urinary retention, all these things are more common with epidural, while ERAS compatibility is good with FPBs as compared to epidural. So to conclude my talk, over the last decade, regional anesthesia has witnessed an explosion of facial bone blocks, many differing only by a few centimeters of probe position, yet acquiring entirely new names. Their success depends less on the name of the block and more on how close you are to the nerve roots, how much volume you inject, and how far it spreads. What truly matters is not innovation for its own sake, but anatomical understanding, as Sandeep Divansar says. Reproducibility, we produce like one case report or a few case studies, and we say that this is the invention by me. But if someone else can't do it, it is not a good block. Safety and meaningful patient outcome. Thank you very much.
Can I now request Dr. Sandeep to kindly take the stage for cadaveric insights?
Sandeep Sarkar.